Welcome to the Musculoskeletal and Connective Tissue lectures. The chapter covers a wide range of topics rather quickly. While there are some high-yield topics covered here, many are fact-based and don't require as much conceptual understanding as they do repetition. We will attempt to provide as many memory aids as we can and pictures to help make this a little easier for you. We'll also indicate specifically which facts are likely to be higher yield than others. To begin, we have the skin, the largest organ in the human body. It is made up of 5 layers as pictured: stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and the stratum bassalis. You can remember this fact with the mnemonic "Californians like girls in string bikinis." Also note that the stratum lucidum is only present in the thick skin of the palms of the hands and the soles of the feet. I recall this by remembering that L, for lucidum, is the only letter in the acronym that's in both the words palm and sole. It's worth going over the different epidermal glands briefly. The first type we'll talk about are the sebaceous glands, which produce the oil that helps keep the skin soft and protected. Their activity increases dramatically at puberty, which is a major factor in the high rates of acne in that age group. They're often used as an example of a gland that works by holocrine secretion, or secretion via breakup of entire cells, rather than exocytosis, so you might want to keep that detail in mind. Eccrine glands are your basic sweat glands that are found all over the body and keep you cool in the heat. Apocrine sweat glands are found in high concentrations in the axilla or armpits and around the genitalia. Their secretions become pungently odorous due to the breakdown of products found in the sweat by bacteria located on the skin. This picture covers a fairly important set of topics. The structures we're about to discuss provide the integrity of epithelium and allow cells to have specific functions. The first structures we'll discuss are the different junctions. Tight junctions, or zona occludens, are found apically along rows of epithelial cells. They prevent diffusion across the paracellular space from large molecules to even individual ions. They're made of 2 molecules, claudins and occludens. Just remember that the tight junctions bind so tightly that they don't allow most substances to pass. The next structure is the zona adherens, or intermediate junction. This surrounds the perimeter just below the tight junctions. The functional proteins that form these intermediate junctions are called cadherins. They attach to the intracellular actin molecules, which normally function in the cell's own cytological skeleton. One interesting fact about cadherins is that they rely on calcium, hence the name cadherin, which is derived from the phrase calcium-dependent adhering protein. So if you ever can't remember what ion is important in their function, just remember that it's in the name. Next we have macula adherens, which are also known more commonly as desmosomes or spot junctions. Again, there's a function clue in the name. Desmo comes from the Greek word for bond. Anyway, unlike the junctions we discussed, these are literally small, discrete sites of attachment, much like a drop of glue. They utilize the same proteins, cadherins, but rather than attaching to intracellular actin, like intermediate junctions, they attach to intracellular intermediate filaments. And yes, we recognize this is confusing and maybe even a little backwards. An interesting clinical correlation for macula adherens is that a disease entity exists wherein patients will have autoantibodies to these spot junctions, often most visible at the level of the skin. If you think about it, if all the epithelial cells lose their spot junctions, they would lose their ability to hold on to each other and therefore separate. If this happened in enough areas throughout your body, it would form large blisters, and this condition is called pemphigus vulgaris, but more on that later. A similar structure to the desmosome is the hemidesmosome, which you see here. It's called a hemidesmosome as it literally functions like half of a desmosome. It does not connect 2 cells to one another, but rather one cell to the basement membrane at the basal portion of epithelial cells. Similar to pemphigus vulgaris, patients that develop autoantibodies to these hemidesmosomes will develop a different blistering disease called bullous pemphigoid. Additional structures are also used to maintain the integrity of the basement membrane, and these are called integrins. They function by binding to laminin in the basement membrane. A final structure found on epithelial cells is the gap junction. These junctions allow adjacent cells to communicate for electric and metabolic functions. This provides an efficient and effective way for one cell to communicate to another. For example, some muscle cells, specifically cardiac muscle cells, will spread electrical signals using gap junctions, so neurons can synapse at a single site, the neuromuscular junction, and still have that message passed down to many cells beyond it. It saves the neuron from having to pass the message individually to every cell itself. This also enables coordinated contraction of the heart from bottom to top, so that blood is pumped out of the heart. Pretty efficient, right? Next, we will make a foray into the wide world of orthopedics. While you may not see a lot of questions about this topic, there are a small spectrum of bone diseases, mostly traumatic and metabolic, that you do need to be aware of. I think this section frustrates a lot of students at first because human anatomy in its totality is extraordinarily detailed, and there are, in theory, an almost infinite number of ways a person can sustain injuries. That being said, however, the way this subject is tested on step 1, there are really only a handful of common, archetypal injuries you really need to understand, meaning that this is a subject that can be memorized like any other. Just try to keep that in mind, and I think you'll make it through the section just fine.
First, let's review some basic anatomy. We have four ligaments, an LCL and an MCL located at the periphery of the joint, and an ACL and a PCL, which you find in the center of the joint. These denominations, A, M, P, and L, all refer to the sites of tibial as opposed to femoral attachment.
The first injury is referred to as the unhappy triad. Imagine a football player that is running for the end zone. To stop him, a defending player may dive through his legs, often from the side instead of from behind him, depending on his position on the field. The resulting hit to the lateral portion of the knee would cause 3 injuries. The first 2 are ligamentous, to the MCL and to the ACL. The third is meniscal, to the lateral meniscus. I keep this all straight by remembering that an unhappy triad injury makes you lame. L, A, M, and then the E doesn't count for anything. L for lateral meniscus, A for ACL, and M for MCL. In certain clinical vignettes about orthopedic traumas, your only clues to certain injuries may be abnormal physical exam findings. There are 2 commonly discussed ones that you will be expected to know for your boards. The first is the positive anterior drawer sign, which indicates a torn ACL. This occurs as the tibia is now able to freely move anteriorly along the fixed femur. Remember that the A or P in ACL or PCL is the same as the direction in which the tibia can freely move when it's injured. I.e., if you have an ACL injury, you'll notice that on physical exam, the tibia can be translated anteriorly, or toward you, the examiner, farther than normal. The second sign is abnormal passive abduction. If you think about it mechanically, abduction at the knee joint is minimized by a strong ligamentous attachment between the tibia and the femur. The MCL. If the MCL is torn, though, these 2 bones could be passively abducted abnormally, leading to a higher clinical suspicion for an MCL injury. In this case, the M or the L in MCL or LCL is the opposite of the direction the tibia can freely move when it's injured. This means that if you have an MCL injury, you should be able to translate the tibia laterally away from the body more than usual. This section highlights certain facts that are important for your ward's experience. As you become experienced clinicians, you'll learn that much of the art of medicine is being able to access human anatomy using certain landmarks. For example, a patient who is in labor may require a pudendal nerve block to decrease pain. This is done by inserting a needle transvaginally and pointing it directly toward the ischial spine, which can be palpated, and injecting it presumptively at the pudendal nerve, which cannot be palpated. Remember the ischial spine for a landmark for pudendal nerve blocks. It's important. Accordingly, when a patient complains of right lower quadrant pain, it's often prudent to see if it occurs in the region of McBurney's point. This location, 2/3 of the way from the umbilicus to the anterior superior iliac spine, is the site of the appendix. A final landmark to be aware of is where to do a lumbar puncture. Most medical students know that the needle should be below the conus medullaris, around the cauda equina, but that information doesn't help you if you're looking at a patient's back. To perform a lumbar puncture, you'll find a place midway between the iliac crests, as this often corresponds to the L4-L5 space.